Good morning. My name is Elizabeth Quinby, and I'm here to present for Team A, diabetes types 1 and types 2. Diabetes is caused by a relative deficit of insulin secretion from the beta cells in the islets of Langerhans, or by the lack of response to insulin. It is a growing public health concern due to its growing prevalence and associated costs and complications. There are two types of diabetes, which we will discuss in the following slides, type 1 and type 2. Type 1, also known as juvenile diabetes, is the most severe form of diabetes, although accounts for only 5% of diabetes cases and is most common in children and adolescents, although it can occur at any age. Although genetics play a factor, insulin deficit occurs due to the destruction of insulin-producing beta cells in the pancreas from an autoimmune reaction. This results in absolute deficit of insulin, which decreases the transportation and use of glucose, in many cells of the body. This leads to an excess amount of glucose remaining in the blood, causing hyperglycemia. Type 1 also has a quick onset. Type 2 is also known as mature onset, as it is common in older adults, of which most are overweight. It is a milder form than type 1 and occurs gradually. Type 2 is most common and accounts for 95% of diabetes diagnoses. In type 2, the pancreas produces insulin. However, the body cells become resistant to the insulin and can no longer use the glucose, which causes the increased glucose to remain in the blood. While both start off differently, they both lead to decreased transportation and use of glucose. This causes hyperglycemia, in turn causing glucosuria, which is high glucose in the urine, polyuria, which is increased peeing. This ensues, resulting in loss of fluid and electrolytes. The patient also has polydipsia, which is increased thirst due to dehydration, as well as polyphagia, which is increased appetite due to lack of nutrients entering the cell. Risk factors for type 1 are unknown, according to Mihan Remus 2018, but may have a genetic component and results from an autoimmune reaction. Both paternal, maternal, and sibling history are shown to be predictive markers in a recent study done by Kusela et al. 2020. They also found that extended family, especially on the paternal side, are also associated with development of type 1. In type 2, obesity ranks number 1 as the biggest risk factor, followed by sedentary lifestyle and familiar history of diabetes. Hypertension and dyslipidemia were found to be predictive, meaning they don't cause it directly, but diagnoses can mean the existence of metabolic alterations such as insulin resistance, which can lead to the development of diabetes. Acute complications include DKA, hyperosmolar hypoglycemic nonketotic coma, and insulin shock. Chronic complications include vascular problems, neuropathy, infections, and cataracts. The next few slides will focus on the acute complications. Most type 1 are subject to acute complications, while type 2 may have longer-term or chronic effects. We will focus on the 3 acute complications. Insulin shock is an excess of insulin, which leads to a drop in blood glucose. This usually happens in type 1 diabetes. The treatment would be to give concentrated carbs, such as candy or sweetened fruit juice, if the patient is awake. If they are unconscious, we are to administer glucagon. DKA results from insufficient insulin, which leads to high blood glucose levels and mobilization of lipids. This process can happen over days, as the lack of glucose in cells results in catabolism of fats and proteins, causing large amounts of acid in their metabolites, which are called ketones. The ketones are released in urine, but as dehydration develops, kidneys can't filter them out, so acid increases, causing decompensated metabolic acidosis. Treatment is hospitalization and immediate insulin, fluid, and electrolyte replacement. Hyperosmolar hyperglycemic nonketotic coma is when hyperglycemia develops due to insulin deficit, although the deficit is not enough to cause ketoacidosis. This results in dehydration and electrolyte imbalance. The treatment is essentially the same as DKA, but replacement of fluid with crystalloid solution is the most important first step, followed by insulin administration and monitoring of potassium. Diagnostic tests include fasting blood sugar, the glucose tolerance test, and the HbA1c, all of which screen people with clinical and subclinical diabetes. The HbA1c monitors long-term, so 3 months, of blood glucose levels by measuring the percentage of RBCs that have sugar-coated hemoglobin. This can be done without fasting and any time of day, unlike the other ones, because it measures an average over the 3-month period. Normal is considered below 5.7. Prediabetes is considered 5.7 to 6.4, and diabetes is 6.5% or above, according to the U.S. Department of Health and Human Services. Knowing your average levels is important for understanding risk of developing prediabetes, type 2, or managing your current diabetes. Although there are many meds used to treat diabetes, metformin is usually the first medicine prescribed to treat type 2 when diet and exercise are not effective. Metformin works by reducing insulin resistance and glucose production. SGLT2 inhibitors are another type of commonly prescribed meds, which work by preventing the kidneys from reabsorbing the sugar into the bloodstream. Finally, insulin is given to help balance the blood glucose levels by acting as a replacement for your body's insulin. It is given IM because it can be destroyed in the digestive tract if taken orally. There are different types of insulin based on the needs of the individual patient to help control the serum levels. There's rapid onset, short acting, intermediate acting, slow onset, and long acting. In summary, diabetes is caused by a deficit of insulin secretion or insulin resistance, which leads to abnormal metabolism of carb, fat, and protein. There's 2 types. Type 1, which requires insulin and is subject to acute complications. Type 2 can be managed with diet and exercise, but may require an insulin if those interventions do not work. And the early signs and symptoms include polyuria, polydipsia, polyphasia, hyperglycemia, and glucosuria. It is important to track blood glucose levels and maintain levels at an appropriate level to avoid unnecessary complications. As practitioners, it is vital we educate our patients on diabetes, assess those at high risk, and provide diabetes management training. Thank you very much, and here are the references.